Hello. Good morning, sir. We are starting the presentation.
Good morning, everyone. Today I am here to present a presentation of synthetic opioids, opioid receptors, receptor profile, and therapeutic use. What are opioids? Opioids are alkaloids found as natural products in opium poppy plant, that is Papaver somnifera. Opioids are any agents that has functional and pharmacological properties of an opioid. Opioids are amongst the oldest drugs worldwide. Opioid receptor ligands. Mainly there are three opioid receptors, mu receptors, kappa and delta. And these are the certain substances which has different action on different receptors of opioids. Opioids antagonist. The main opioid antagonists are naloxone and naltrexone. Naloxone is used in acute poisoning and naltrexone is used for withdrawal. And they are antagonists at mu receptors, delta and kappa opioid receptors. Opioid receptors. There are mainly three types of opioid receptors: mu opioid receptors, delta and kappa. They belong to rhodopsin family of G protein coupled receptors. Opioid receptor structure. There are mainly 7 transmembrane helices, 3 extracellular loops, and 3 intracellular loops. Opioid receptor signaling. Mu, delta, and kappa receptors are coupled to G proteins, that is G inhibitory or G excitatory. On receptor activation, there is protein coupling, which leads to a number of intracellular events that are mediated by alpha and beta gamma subunits of G proteins, which leads to intracellular events. The main intracellular events which leads to the effects of opioids are inhibition of adenyl cyclase activity, reduced opening of voltage gated calcium channels, and stimulation of potassium current. Opioids are mainly divided into 3 categories: natural, semi-synthetic, and synthetic. Natural consists of morphine, codeine, thebaine, and papaverine, and semi-synthetic consists of heroin, ethyl morphine, and hydrocodone. Synthetic opioids consist of fentanyl, remifentanil, and tramadol. Now we are moving towards therapeutic uses of opioids. Opioids is mainly used as analgesics, and morphine is indicated especially in traumatic, visceral, ischemic, post-operative burn or cancer pain. As pre-anesthetic medication, morphine and pethidine can be used in few cases as pre-anesthetic medication. Balanced anesthesia and surgical analgesia. Fentanyl and remifentanil or morphine are important components of intraoperative anesthetic technique. Opioids are also found useful in some cases to relieve anxiety and apprehension. The most common use of opioids is acute left ventricular failure and acute pulmonary edema, as they have vasodilator property. Cough. Codeine can be used in cough syrups to suppress the cough. Diarrhea. Opioids are mainly used in irritable bowel syndrome, mainly loperamide. Some of the synthetic opioids and their uses. Fentanyl is used in neuroleptic analgesia, anesthesia, and sequential opioid anesthesia. L-fentanyl is used in total intravenous anesthesia along with propofol. Sulfentanyl is used to block stress response in intubation and bronchoscopy. Remifentanil is used in day care surgery as it is shortest acting and fastest action. Tramadol is used as analgesic in mild to moderate pain, and along with it, it inhibits the reuptake of serotonin. Good morning, everyone. Myself, Akshit Vasist. I am here to present presentation on topic synthetic cannabinoid receptor profile and therapeutic use. My moderator is Dr. Tanya Garg. Introduction. Cannabinoid are the most widely used illegal drug in the world, also called as marijuana, psychoactive component delta 9 tetrahydrocannabinoids, also known as gateway drug. Plant cannabis sativa. Male and female plant are separated. In male plant, pollen sac, cannabis are seen in pollen sac, female plant, white pistil, female plant, highest concentration of tetrahydrocannabinoid. Flowering top has highest amount of tetrahydrocannabinoids. Tetrahydrocannabinoid concentration in marijuana 0.5 to 5%. The concentration. Preparation of cannabis. Marijuana flowering top and leaf source tetrahydrocannabinoid level 1 to 3%. Hashish charas source dried cannabis resin tetrahydrocannabinoid level 10 to 20%. Hash oil extracted tetrahydrocannabinoid from resin source tetrahydrocannabinoid level 15 to 30%. Ganja source dried buds and flowering top of female plant tetrahydrocannabinoid level 6 to 20%. Bhang source cut and dried large leaves and stem of plant tetrahydrocannabinoid level less than 0.3%. Synthetic cannabinoid. Synthetic cannabinoid are human-made mind-altering chemicals that are either sprayed on dried, seeded plant material, so they can be smoked or solid as liquid to be vaporized and inhaled in e-cigarette and other devices. These products are also known as herbal or liquid incense. These chemicals are called cannabinoids because they are similar to the chemical found in marijuana plant. Because of this similarity, synthetic cannabinoids are sometimes misleadingly called synthetic marijuana fake weed, and they are often marketed as safe, legal alternatives to that drug. In fact, they are not safe and may affect the brain much more powerfully than marijuana. Their actual effect can be unpredictable and in some cases more danger or even life-threatening. How do people use synthetic cannabinoids? The most common way to use synthetic cannabinoid is to smoke the dried plant material. User also mix the sprayed plant material with marijuana or brew it as a tea. Other user buy synthetic cannabinoid product as liquid to vaporize in cigarettes. Group of synthetic cannabinoids: naphthol, inidols, naphthyl methyl inidols, naphthol pyrols, phenyl acetyl inidols, cyclohexylphenol, naphthyl methyl inidans, classical cannabinoids. Receptor for cannabinoids. Cannabis exerts its effect on human function primarily through an endogenous cannabinoid receptor system. This endogenous system has only been discovered, and to date two receptor subtypes CB1 and CB2 and five endogenous ligands have been identified. The psychoactive and reinforcing effect of cannabis are primarily mediated by activation of CB1 receptor by tetrahydrocannabinoids. The CB1 receptor is presynaptic G protein coupled receptor, activation of which inhibit adenyl cyclase and voltage-dependent calcium channel and activate potassium channel mitosin activated protein kinase. Receptor distribution. The CB1 receptor is abundant throughout the CNS, but it is expressed in the brain at the highest concentration in the basal ganglia, cerebellum, hippocampus, and cortex. Changes in brain activity following administration of tetrahydrocannabinoids are localized mostly in these areas, which are consistent with the behavior effect of cannabis, and imaging study indicate that this brain activity changes are tetrahydrocannabinoids dose and time dependent effect. Tetrahydrocannabinoids also appear to enhance the dopamine neuronal firing and synaptic dopamine level in the reward pathway of brain, and also enhance electrical brain stimulation reward. Determination of distribution of CB2 receptor has lagged considerably behind that the CB1 receptor. There are many reasons for this, including the lower abundance of CB2 receptor relative to CB1 receptor. Receptors are difficult in raising highly selective CB2 receptor antibodies. Nonetheless, strong evidence supports that the motion that CB2 receptors are expressed on number of immune cells such as macrophages and neurons. Effect of synthetic cannabinoid. Synthetic cannabinoid usually report some effect similar to those produced by marijuana. Elevated mood, relaxation, altered perception, delusion and disorder thinking detached from reality. Psychotic effect include extreme anxiety, confusion, hallucination. Medicinal use. Synthetic cannabinoid like dronabinol and nabilone are licensed for the treatment of weight loss in patients with AIDS and of nausea and vomiting in people receiving chemotherapy who have failed to respond adequately to conventional antiemetic drugs. Some cannabinoids are found to be effective in clinical trials of multiple sclerosis, arthritis, and neuropathic pain. My references are Lovinson and Ruiz, Substance Abuse Comprehensive Textbook, 5th edition. Thank you.
Next presentation is by Dr. Abhishek, SNRI.
Good morning, everyone. Myself Abhishek Garg, and my topic of seminar is SNRI, and my moderator is Dr. Tanya Ma'am. Now, what are SNRI? SNRI stand for Selective Serotonin Norepinephrine Reuptake Inhibitor. They are dual reuptake inhibitors. Now, their mode of action: SNRI inhibit the reuptake of serotonin and norepinephrine in synapse. This leads to increased synapse and norepinephrine levels in the synaptic cleft. Therefore, there is enhanced serotonergic and noradrenergic neurotransmission, which is depicted in this diagram. Now, 5 SNRIs which is approved in US are venlafaxine, desvenlafaxine, duloxetine, milnacipran, and levomilnacipran. Now, uses of SNRI: there is depression, generalized anxiety disorder, panic disorder, post-traumatic stress disorder, stress urinary incontinence, fibromyalgia, social anxiety disorder, and neuropathic pain. Now, individual drugs. First is the venlafaxine and desvenlafaxine. It is first synthesized in 1970. It has greater affinity for serotonin transporter Immediate release formulation for venlafaxine was FDA approved in 1994 for major depressive disorder. Extended release was introduced in 1997. Active metabolite is O-desmethyl venlafaxine. Now, venlafaxine has lack of affinity for muscarinic, histamine, and adrenergic receptor. It do not inhibit monoamine oxidase. Venlafaxine is essentially an SSRI at lowest therapeutic dose, which is 75 milligram per day, and that noradrenergic effect increase progressively as dose is advanced. Now, during venlafaxine therapy, O-desmethyl venlafaxine accumulate twofold. Then O-desmethyl venlafaxine account for majority of its therapeutic activity. Co-administration of food decrease the rate, not the extent of absorption. It is eliminated by kidneys. Elimination half-life of venlafaxine is 4 hours. Elimination half-life is of O-desmethyl venlafaxine is 10 hours. Now, its clearance reduced in cirrhosis and severe renal disease. Therapeutic indication are major depressive disorder, generalized anxiety disorder, social anxiety disorder, panic disorder, attention deficit disorder. Now, this venlafaxine is the only FDA approved for major depressive disorder. Now, side effect is nausea, sexual disturbances, headache, insomnia, somnolence, dry mouth, constipation, sweating, and hypertension. Now, second is the duloxetine. It is more potent for norepinephrine reuptake inhibition than venlafaxine. Dual reuptake inhibition at lower absolute dose. It is FDA approved for major depressive disorder in 2004. Now, milnacipran. It is a potent inhibition of norepinephrine reuptake than serotonin at a dose of 50 milligram per deciliter and on serotonin at 200 milligram per deciliter. Its half-life is 8 hours. There is no active metabolite. It is most bioavailable. Side effects are dizziness, sweating, urinary hesitancy. Now, levomilnacipran. It is an active enantiomer of milnacipran. Its half-life is 12 hours. It is effective in age more than or equal to 60 years. It is orally well absorbed. There is no active metabolite. Now, side effects are nausea, high blood pressure, anticholinergic side effects, discontinuation syndrome, sexual dysfunction. It is contraindicated with monoamine oxidase inhibitors. Now, drug interaction. Well, 14 days are suggested to elapse from ending MAO inhibitor therapy and starting venlafaxine treatment. An interval of only 7 days after stopping venlafaxine is considered safe before beginning MAO inhibitors. Duloxetine has a similar interval to initiation following MAO inhibitor therapy, which is 14 days, but require only a 5-day waiting period to begin MAO inhibitors treatment after ending duloxetine. Now, discontinuation syndrome, it is seen with all SNRI, but most commonly seen with venlafaxine. Appearance of side effect during rapid tapering and or rapid cessation are dizziness, dry mouth, insomnia, nausea, nervousness, sweating, anorexia, somnolence, and sensory disturbance. Thank you. Reference is CTB.
Any questions?
Okay, so nice presentation, I think, by all the three presenters. I think that, am I audible? Can you hear me? No. Am I audible? Can you hear me?
Thank you, Dr. Akash, Akshit, and Abhishek for the presentation. Now we like to felicitate them with certificates. Thank you.